Well, thanks for coming out tonight. We're doing kind of a combo lecture tonight. We've based talks throughout the last couple of years. We're doing them kind of be seasonal, and intentionally, this one was planned to be carbon monoxide injuries, which we've done before, but we added burns to it because we're coming to the season now where uh, you do tend to see more fire injuries. You certainly see more inhalation carbon monoxide injuries. So that's what we're doing tonight. Burns, we've talked somewhat about in the past, but it's amazing how many people get burned every year. And it's between 1 and 2% of the population. Now, most of the deaths and most of the admissions come from structure fires, but there's 1.5 million people treated annually for burns in this country. 50,000 of those get put in the hospital. Again, most of those are from structure fires, and that's where 50% of the deaths occur. They're somewhere in the range of 5,000 deaths a year. As you can figure, the causes of burns, we've all seen it. Smoking in bed, light off the mattress. Cooking injuries, particularly the elderly, they're leaning over a stove, particularly a gas stove. They set their clothes on fire. We had a special lecture on electrical injuries, and that still is a major cause of burns. Heating systems or malfunctioning systems, of course, arson, and in kids, the most common cause of burns are scald injuries. The, the degree of burn, the severity of the burn, really is greater with immersion and with time of exposure, as you would expect. When you get a hot water tank put in your house, you'll notice that it's set whatever number, 110, 113. In our house, it's just like the water just doesn't feel hot enough. Well, they put it there for a reason, and so theoretically, people can't get burned. So if you get 110 degree Fahrenheit water, remember our body is somewhere between 95 and 100 degrees, you can get some minor delayed burns, but water up around 120, 125 degrees, you can get burned in a matter of seconds. 160 degrees can be fatal and can cause full thickness burns. So again, it only makes sense if you get splashed, you have a very quick exposure. If you get immersion, you have a longer exposure. I can still remember one of the child abuse cases that I saw in South Carolina where a kid was brought in supposedly having dumped scalding water on him or herself, and it was a fairly small child. And the burns were on the lower legs and on the buttocks, and the knees on both sides were spared. How in the world did that happen? Well, it's classic. Someone's dunking a kid in hot water and the baby's pulling its legs up. It's it's a classic injury, but the child was held in hot water and had full thickness burns. Electrical burns we've talked about in the past, and again, electricity travels through tissue. Depending on what tissue it's traveling through, it generates heat. That heat can cause burns. So each of our body tissues have a different resistance. So it travels fast and can generate a lot of heat, for instance, going through fatty tissues. But electrical burns are about 10% of all burn injuries. So the temperature and the damage depends on whether it's a high voltage injury or a low voltage injury, on the amperage, basically what's the voltage and how fast is it coming through. And again, duration of exposure. Most of the time in the key and burn injuries, we're going to talk about gauging percentage of burns and total body surface area, but most of the time we underestimate electrical burns because we can't see. We can see an entrance, sometimes we can see an exit, but we can't see what happened in the deep tissues in between. So all of us, from those in the field to those in the emergency department, tend to underestimate electrical burns when we first see them. As you would expect, burn deaths are worse or higher in the very young and the old. The young being less than 5, and I just refuse to accept that old is considered 60, but it is statistically. And that's where your extremes of age and your mortalities come. Most of the causes of death related to burns are from smoke inhalation, and we we see these terrible cases of people brought out of houses completely burned. And in many cases, they were dead before they ever got burned from the carbon monoxide and the smoke, which we'll talk about in just a little bit. So causes of death: smoke inhalation, as you would expect, then hypovolemia and shock, fluid losses, hypotension, shock, and then you start getting the delayed causes: wound infections. You get infections, you get overwhelming sepsis. If you get all through all that, people who lay around in bed, can't be mobile, tend to get other illnesses like pulmonary emboli, like deep vein thrombosis if they're not anticoagulated, but importantly, pneumonia as well. So how do we calculate how much of body is burned? We've been using the rule of nines for years, and it still is a good generalization. And you just have to remember that you break the body into the head, the trunk, the back, the arms, the legs. So the head, on average, in an adult is 9%, and this is an estimate, 9% of total body surface area. The chest and abdomen is 18%. You turn around, same area in the back, 18%. Each leg, 18%. Each arm is 9%. And then the genitalia and perineum is 1%. So if you go through and say, well, you've got burns pretty much on the front of the body, so it'd be half the leg in the front would be 9, 18. So you can go through and calculate up, but that totals up to 100%. Now, when we talk about what's the prediction of mortality with burns, one way of doing it is the formula where you say age plus percent body surface area burned. So if you have over 70% total body surface area burned and you're 60 years old, you add those two together, you get a score of 130, you've effectively got 100% mortality. So when you talk about the older you get and the more surface area you burned, the number is greater than 130, you've got virtually 100% mortality. And inhalation injuries add to this. Probably a better estimation is looking at risk factors. So if you look at risk factors for burn mortality being age over 60, inhalation injury, and 40% total body surface area burn. And we're talking second and third degree burns. So if you don't have any of that criteria, in other words, you're not over 60, you don't have an inhalation injury, let's say you've got a 10% total body surface area, you virtually have no chance of mortality. It's something like 3 in 1,000, very low. But if you add in one factor, you're over age 60 with that same burn, now you're getting up to, all right, 3 in 100, 3% chance of mortality. Two factors, let's say you're over 60, you've got an inhalation injury to go with a 10 or a 20% burn. Well, now you're at 33%, and if you got all three factors, 90% chance of mortality. So remembering age, is there an inhalation injury, and how much body surface area. If you've got more than 40% burned, that's a risk factor. So age, inhalation injury, total body surface area, more than 40%. So we talk about the dynamic injury of a burn. When you get burned, it continues to burn until we get away from the source and we get things cooled down. So the extent of the injury really depends on the temperature of the source and depends on the duration of exposure. At over 113 degrees, we begin injuring cells and superficial and as well as deep tissues. And at 131 degrees, we start getting full thickness injuries. What do we mean by full thickness? Skin, subcutaneous tissues, and basically down to the bone. So the epidermis, if you remember, is our skin. It's the protective layer. It protects us from radiation, UV radiation, protects us from heat. It's a barrier against bacteria. For basically, it's the protection of our body, and it protects against fluid loss. Underneath that is the dermis, which really is where the strength of the skin comes from, the connective tissues, but it's also the area where we have the small blood vessels, the sweat glands, the hair follicles, the nerve fibers. So in all burns, you tend to get a very intense inflammatory response. That's the redness you see. When you get that, the capillaries leak. Those capillaries leak. The fluid goes into the soft tissues around there. It's called third spacing of fluids. The vessels are dilated up, and that's typical in first and second degree burns. Major burns can lead to multi-system organ failure. You get someone with massive third degree burns, it's not only the burns, but then you start getting renal failure and multi-system problems, respiratory system failure. So it depends on, again, the depth of the injury and the extent of the injury. So the depth of the injury, whether it's first, second, or third degree, really determines the outcome. Most of superficial burns, very topical, sunburn, they heal in days to a couple weeks. Deeper burns can take several weeks to heal. And really then you can also start getting loss of function. You can get scarring, you can get nerve damage and vascular damage. So we talk about first degree burns. We're talking about something like a sunburn. You have involvement only of the epidermal layer. It's red, it's painful because the nerve endings are irritated. If you push on it, it blanches. You take your thumb away, it turns red again. But there's no break in the skin, there's no blister formation. And typically, it resolves in several days. Most of these come from sunburn. That's the major cause of first degree burns. The other cause are typically splash or scald injuries. So someone got some hot coffee splashed on them, or they got some hot water splashed on them, something like that, which caused a localized area of redness. But again, the skin's intact, it's painful, there are no systemic problems typically from a first degree burn. Now, second degree burns are the ones that are really painful, and they come in superficial and deep versions because they involve the epidermis, but they also involve the layer right underneath. So they involve where the nerve endings are at. And they typically have blisters or bulla formation, sensations intact. It hurts. You can often involve some of the hair follicles. And again, it comes from scalding burns, from flash burns, a flash over, real quick burst of heat, or brief contact, lay your hand or lay something against a very hot object and pull it away very quickly. So again, it's brief contact for superficial burns, but these are the ones that really hurt. Now the deep second degree burns, many times hot grease is a culprit here. So someone gets, we had a patient recently who caught their pants on fire, put the pants out, had a fairly deep second degree burn on the leg. Hot grease doesn't cool off very fast. When it hits the skin, it's still hot and it's still cooking. And that's why it causes some of these deeper burns. You can get some scarring, you can get some cosmetic disfiguring with deep second degree burns, and they can take 4 to 6 weeks to heal and are quite painful. Well, third degree burns are full thickness. And interestingly, a true third degree burn is painless because you've destroyed the nerve endings. Now, the area around them where there might be a second degree burn on the margins is where the pain comes from. But a third degree burn is full thickness. It involves all the skin layers, all subcutaneous layers, doesn't heal by itself. Many times require surgical intervention. So the nerve fibers are destroyed. It looks like shoe leather. It's hard. And this comes from direct contact with flames, prolonged exposure to hot objects. Some chemicals can cause third degree burns, but these are the ones that are really problematic. So we classify, so we talk about first, second, third degree burns, and now we talk about are they minor, moderate, or severe as far as to the patient. And this really is looking at total body surface area. So we've estimated the body surface area. We've decided is it first, second, or third degree, based on what it appears to be the depth. And we only count really second and third degree burns in total body surface area calculations. So if we talk about a minor burn in kids and adults, that's a burn, second or third degree burn, that's less than 5% of total body surface area. Now, that's not a very big area. If you talk about, uh, your trunk's 18%, so that'd be a quarter of this, or an arm, 9%, so half an arm. So a third degree burn, less than 5% total body surface area, that doesn't involve inhalation, so the patient doesn't have any soot in their airway, they're not having any trouble breathing. Obviously, they're not intubated. They're normotensive. You get their vital signs. Their blood pressure is, of course, it may be up a little bit, but they're not hypotensive. Those would be considered minor burns. Additionally, it can't cross a joint line. So when you start crossing joint lines with burns, you start getting into other problem areas, and it can't involve some really key areas, such as the face, the hands, the genitals. The burn center criteria, it doesn't take much when you burn a hand to get into the burn center, because now we're worried about burns on and scarring and function. The face, obviously, we're worried about cosmetics. Genitalia, for obvious reasons, painful. Function, again. So the feet, the hands, the genitals, the face are, if you're burned in those areas, it is no longer considered to be a minor burn. We talk about serious burns, moderate burns in kids and adults. And again, we're talking second and third degree burns. You're above 5%, but less than 15% of total body surface area. There may be a suspected inhalation injury. It may need airway support. They may have an altered mental status or a low blood pressure. So this kicks them into any of that criteria, into serious burns. And severe is obviously greater than 15%, second or third degree burns, any airway compromise, burns associated with multiple trauma. So we talk about critical areas of the body, the things that land you in a burn center, although it seems like it's not very much of a body surface area. Well, second or third degree burns of the face are cosmetic and can certainly be disfiguring. We talked hands and feet is functionality. If you work with your hands and you have to use your fingers and you get a circumferential burn, involve the web spaces, and that thing heals, all of a sudden you can't bend your fingers, you're effectively disabled. The perineum, you're talking about soiling and pressure injuries. So I mean, you have to sit, you have to lay, you have to void, you have to defecate. So constant exposure and infection. So any burns in the perineum are problematic. And then any circumferential full thickness burn, and particularly you talk about circumferential, you're talking about the extremities. So if you get a burn that goes clear around, and now you've got tissue that is constricted, you can get compartment syndromes, you can get vascular compromise, nerve compromise, circumferential burns of the chest, same way. All of a sudden you can't expand your chest to breathe. So those are real problematic, and those are critical areas that we look for. So pre-hospital care. Airway always first. Always consider carbon monoxide exposure. All these folks, if they've been exposed, any significant burn, they need oxygen. We always look for upper airway injuries. And these are folks that are real problems, because the question is, do we do an airway procedure while we're sitting there looking at them and they're talking to us, or do we wait a while? But if they've got facial burns, they've got soot in the nose, you look in the back of the mouth and you see black stuff way back in their throat. If they're coughing and they're hacking out black stuff, they've got an inhalation injury. And they might be looking good to you right now, but in 10, 15, 20 minutes, they may not be looking quite so good. You want to know, were they trapped in a closed space? And obviously the exposure to smoke and carbon monoxide is consideration there. And so the take home here is, these folks, if you've got someone who has potential inhalation injury, the things we just talked about, you've got to be prepared to intubate early, and you've got to be ready to do an emergency airway procedure. So all these folks get fluids. Anybody with more than 20% total body surface area in adult or 10% in kids, they need to get IV fluids, preferably large bore IV, preferably lactated ringers. Saline is fine if you don't have LR. You want to know what happened. You don't know when it happened. How long was the exposure? How long were you in the house? How long were you exposed to this source? Ample history, allergies, medications, past medical history, last meal, events. Obviously, you want to know the things we've talked about in the past. If someone has COPD, they've had a minor exposure, it can be problematic. I'll tell you what, if you've got COPD right now and you live in Charlotte, you've got some problems, with air quality coming from the fires. How about you got COPD, now you're just exposed, the next room caught on fire, and you're outside. I mean, so those are the things you're looking for when you talk about history, in addition to the burns. And you really want to know what happened. So what other first aid measures? Watch for C-spine injuries. We don't use boards anymore, or very rarely. If there's a history or a question of a C-spine injury, get them in a collar. Cool the burn. And this sometimes is overlooked, but the fact is it's really comfortable to the patient when they come into the emergency department or the clinic, and we just put on towels and put on ice. The fact is that tissue is still cooking, particularly you get out there and it's red and it hurts. It's gross. It's like the steak you took off the grill and you're letting it rest. Well, that tissue, deep tissue, is still hot and it's still being damaged. And the more we can cool it down, we can decrease the depth of the burn, particularly in those first 60 minutes. So using cool saline or tap water, we don't put ice directly on the wounds. It's nice to put a moist towel and something cool above that. If it's a chemical burn, you'll never be wrong pouring the water on it in most cases. And you don't break the blisters. You leave the blisters intact, and we deal with them later on. Inhalation injuries, they all get high flow oxygen. They all get IV fluids. Talk about carbon monoxide or cyanide in a couple minutes. And then burns are painful. And so once you get all that under control, treating the pain, and again, if you're treating burn pain, fentanyl is an ideal medication because you can titrate it up. It doesn't last long. If you need more, you can give more. So what about fluids? There's a lot of burn formulas. The standard for years has been something called the Parkland formula. And so you calculate the percentage of total body surface area that's burned, of second or third degree burns. You figure out what the weight is. So let's say that someone weighs 80 kilograms and they burned 20% of their body. And you're going to give them 4 cc's per total body surface area per kilogram. So you figure it out, it's a lot of fluid. So 80 times 20 is what, 1,600 times 4, 4,000 to 6,400 cc's of fluid. So 6.5 liters of fluid that patient would get over 24 hours, with half of that coming in the first 8. So talking about people who get burned get a lot of fluids in that first day, and you're trying to keep their kidneys, you're trying to keep urine output so that as muscles have the breakdown products, you don't get basically plugging of the kidneys, if you will. So the goal is to keep the organs perfused, keep urine output going, avoid hypotension and shock. Wound care, first degree burns, pretty simple. Use non-steroidals, Motrin, Aleve, stuff like that. Topical agents, there's no magic. These things get better by themselves. Second degree burns, like to leave the blisters intact. Why? Well, that's our natural protection. If that blister stays intact, over time it goes away. You take it off, now you got a raw piece of exposed skin which has a chance of getting infected. Silvadene is kind of the classic treatment. It's very soothing. It's good on extremities and the face. A lot of surgeons prefer just plain bacitracin. Once you've gotten past the initial phase, aloe vera cream or lotion tends to be a good anti-inflammatory and wound healing, but most of the stuff here is pretty simple and straightforward. Third degree burns, almost all of them require surgical repair, either excision, skin grafting. They're not going to get better by themselves, and obviously it depends on the size of the burn. So who gets transferred to burn center. Um, it's interesting when you're in emergency medicine, you're trying to transfer patients, and you get hassled. One thing I'll tell you, the burn center is probably the easiest place to get somebody into that I've experienced because it doesn't take a lot. We talked about certain critical body areas, but uh, they know that that's what they do, and if they've got the beds available, they're going to take the patient. So, second degree burn, more than 10% body surface area, doesn't sound like a lot, but that's enough to get you in. Obviously, what we talked about: hands, feet, genitalia, anything crossing a major joint, which may cause restriction of motion when it heals. All third degree burns, electrical burns, including lightning burns, chemical burns are a unique subset. Uh, Burns with inhalation injuries, burns and trauma, burns and other medical problems. And so those criteria, basically, if you see that, it's going to be off to UNC directly in many cases. So high risk, again, we just talked about some things, but the high risk, someone's under 5, over 60, any circumferential burns, steam injuries are problematic because, again, you have really high temperatures and you tend to underestimate the damage, and steam has so much heat that it continues to cook. High voltage energy, we talked about, or high voltage electrical injuries, and then some special things like hydrofluoric acid burns or ionizing radiation. So, kind of summary of burns. The acute phase, death is from typically inhalation or hypovolemia. When we're talking about total body surface area and burn criteria, we're talking about second and third degree burns. And we want to just kind of remember what the criteria for burn center transfers are. And I would say, when in doubt, go to the burn center. So we talked about part of this of exposure and deaths in house fires or those situations being from inhalation injuries. And again, there's a lot of deaths that come from carbon monoxide every year. And this is the time of year where that diagnosis tends to spike up, and it also tends to get missed. I can remember as a medic in Bridgeport, West Virginia, being called to a house, whatever time of day it was, for a family with the flu. A whole family, all 5 of them had the flu, and they all had an onset of symptoms at the same time. They didn't have the flu. The furnace was malfunctioning. They all had carbon monoxide exposure. So this time of year, patients come into clinics, to their doctor, to our clinic, to the emergency departments. They come in with flu-like symptoms. I got this headache. Well, yeah, it sounds like flu, but the questions got to be asked are, if things aren't fitting, do you have gas furnace? Do you have any flame in your house? So there's about 2,500 deaths a year in this country from carbon monoxide exposure. Again, it spikes in the winter. Many of these cases are intentional. Those don't spike. They're year-round and suicides. But it can be a diagnosis that's sometimes difficult, and it certainly is easy to miss. But it's a very, very toxic poison. Odorless, colorless. It's just innocuous. The patient goes to sleep and doesn't wake up. And what has been realized in the last 20, 30 years is that the old thought was, get them out of the environment, give them oxygen, they'll get better. But now there has been good data that there's some delayed neurologic problems with significant carbon monoxide exposure. So in emergency medicine, emergency treatment is preventing the respiratory failure, getting them oxygen, and getting them to the right place to prevent long-term problems. So we talk about its peak incidences now. It's really when the cold weather starts. The intentional exposures are year-round, and this carries, in many cases, a fatality of 30%. So, colorless, odorless gas, anything that has a flame can make carbon monoxide, and that's the simplest description. So, you see these internal heaters that have flame and they're ventless. They're still making carbon monoxide. You can come from paint strippers and metabolize, but we talk about 99.5% of the stuff that we see of carbon monoxide exposure, there's going to be a flame involved, a gas, a propane engine, something along those lines. So talk about kerosene heaters, gas stoves, wood burners, charcoal grills. Charcoal grills are probably the highest concentration of carbon monoxide. And we've had a couple cases. I've seen one, and it's been in the literature, where people went to parties and they left and put the charcoal grill in their trunk to take it home, and it was still smoldering, and they never made it home. Uh, Fireplaces, internal combustion engines, shop heaters, all those things, anything with a flame can generate carbon monoxide. So, as you would expect, there are certain people at risk. If you fly in a single engine Cessna, you do it for fun, or you've flown with people, you notice one of the things on the dashboard is a carbon monoxide detector. And every small plane sitting right in the middle of the dash is a CO detector. And private airplane pilots, you get up there and this thing's malfunctioning, they don't know it. Um, Boaters, and we'll see a case or two every year, you see where an inboard motor and running, and something happened. Over the road truck drivers, obviously firefighters, people doing what we do, are at risk if they're around flames. So the symptoms really depend on the concentration of carbon monoxide in the atmosphere and how long you're exposed. Low exposures, may go unnoticed. And in fact, there are people that have gone all winter long saying, I kind of get a headache on and off, and you come to find out they just had continuing low-level exposures all the time and were symptomatic. On the other hand, someone can walk into a very high concentration and in a matter of minutes be unconscious. So we measure the concentration in the room in parts per million. So if you've got a very low concentration, 30 parts per million, you average that over 8 hours, you're not going to have any symptoms. You get up to 200 parts per million, you're probably going to be symptomatic. And 800 parts per million for 2 hours is probably going to be lethal. So one of the things, in addition, every house, obviously, every dwelling should have smoke detectors. Every house that has anything with a flame in it should have a CO detector. And these things are cheap, sold at Lowe's, are really good devices, and the ones that are really good are the ones that also give you a readout on level. So they should alarm at somewhere greater than 100 parts per million. So if you've got 400 parts per million for a couple hours, you'll get headaches. And if you've got it for 3 to 5 hours, you may end up getting a long sleep. So how's this work? So what's carbon monoxide do? It competes basically for oxygen on hemoglobin. If we go back and remember, hemoglobin carries oxygen. That's its role. It picks up oxygen in the lungs, it dumps it at the tissues, comes back, picks it up again. So our oxygenated blood is red, our deoxygenated blood is dark. But what carbon monoxide does is it binds hemoglobin, and it's like a magnet on hemoglobin. It binds it more so and tighter than does oxygen. So hemoglobin given carbon monoxide or given oxygen will bind the carbon monoxide. And so now the hemoglobin is not carrying oxygen. The problem is at the end organ, at the cellular level, where you've got hypoxia. As you would expect, the tissues that are most sensitive or need the most oxygen are the ones that are affected quick. Our brain needs oxygen. It needs sugar, needs oxygen. You take either one of them away, things don't work right. So the brain, you get decreased mental status, confusion. Heart, working 60, 80, 90 times a minute, not enough oxygen, it can't work right, so it alters the contractility. It causes smooth muscle relaxation, so the vessels can't constrict and dilate as they would keeping control of blood pressure, so they dilate up and your blood pressure goes down. So now you can't perfuse the tissues. So if you think about all this, someone who's got pre-existing disease, we just talked a little bit ago, so someone with COPD who's in a horrible air environment out in our western part of the state, they're going to have problems. Well, likewise, someone with bad coronary artery disease who gets exposed to carbon monoxide, now they don't have the oxygen carrying capacity they're going to have problems. And so you always think about the disease entities the patient has and what might go wrong now that they've had this exposure that might not be terribly bad for somebody healthy. So what can it cause? You know, heart attack, myocardial infarction. Same thing, the brain can cause a stroke, can cause heart irregularities. If the heart's not pumping well, you don't have the contractility, you can get pulmonary edema, congestive heart failure. And then we talked that we know that in half the cases of significant carbon monoxide poisoning, several weeks down the road, patients actually can develop dementia-like symptoms and Parkinson-like symptoms. So we talked about missing it, and it's flu-like symptoms: nausea, vomiting, muscle aches, dizziness, headache, weakness, just don't feel good. And I think we've all had that. It's like, I got no energy, my muscles hurt, I'm just a little nauseous, I don't want to throw up, but I just don't feel good, and I got this low-grade headache. I had a close call like this. It's been a good 10 years ago, and I have a garage. It's detached from the house, and I had a kerosene heater going downstairs. And I was upstairs working on my bikes. That's when I was still riding a bike. And I was up doing some bike maintenance, and I just started not feeling good, and got a headache. I thought, I know what this is. And I went down. Sure enough, this kerosene heater was all sooted up and was not burning, as well as it should. But I felt like crap in a hurry. And, it's, you think you got the flu. No, it's something you have to watch out for. So you've got to consider this when there's clusters. Yeah, you can get flu in families. Obviously, it spreads around. But if you've got a group of people who all come down with the same constellation of symptoms within just a very few minutes of each other, you got to think of something else. And you've also got to think, it's like you get them out of the house and they feel better. Yeah, this isn't viral. This is not flu. This is carbon monoxide. So you look at things like, do they all have the symptoms starting at the same time? You get them out of that environment, they start feeling better. You look at maybe the windows have excess moisture, maybe the air circulation in the house hasn't been good. If it's something they've been suffering, it's like they notice it when they turn the dryer on or the furnace comes on or something like that. So there are a lot of questions you can ask and get to the bottom of this. So mild cases: fatigue, headache, muscle aches, nausea, vomiting. Severe cases: chest pain, shortness of breath, passing out, staggering, stroke-like symptoms, seizures, and becoming unresponsive. What's interesting about this is the standard pulse oximeters that we use really are of no value, because that technology is good. What it's doing is it's measuring the saturation of hemoglobin. It doesn't matter what it's saturated with. Yeah, that hemoglobin is 96% saturated. Well, the fact is it's saturated with carbon monoxide. Now, there are co-oximeters now that, I think Massimo is the maker of the one that I know of, that actually can measure that. They're about $7,000 or $8,000. So, as you expect, it's an expensive device. But a normal pulse oximeter, someone comes in with what you think is carbon monoxide level, and you are poisoning, you put a pulse ox on them, and their sats maybe 95, 96%. Can't tell. So you can get fooled by pulse oximetry. So you got to have history. You can get venous carbon monoxide levels. Arterial blood gases were the old way. Now a lot of times we just do the CO levels of venous, or you can use one of these expensive oximeters. But the big thing is recognizing the problem. So if you know there's evidence of combustion at the scene, there's odors combustion, the patient's got these symptoms, you've got to suspect it, and you'll never be wrong assuming they have it and treating them for it. So you got to think of it. If you don't think of the problem, you're not going to find the problem. You got to gather the evidence. Are the pets acting strange? I've never had a pet that didn't act strange. But, literally, if the pets are acting drunk and the pets are staggering around, it's like, the pet doesn't have the flu. Are there multiple folks sick? They get better after leaving the scene. Do we smell stuff in the house? Those are things that would tip you off. That cherry red skin, that's an autopsy finding in many cases. It's just not something that we see. It's less than 10 or 15% of victims, and many times those are the victims that have been laying down, and they're actually getting some pressure necrosis. So it's a late finding that we don't even worry about that. So most of us in here right now, non-smokers, we're sitting here in an air environment that's good. We have 0 to 3% carbon monoxide level. That's normal. So you go outside and you smoke a cigarette, and if you're smoking a pack a day, so you're smoking fairly often, you're walking around with a 5 to 7% level. Cigar smokers up to 10%. I don't know if anybody ever smoked cigars. I tried it once or twice, and I got the worst headache. Well, the headache was from carbon monoxide, probably, but you get levels of up to 10% in cigar smokers. And the thing that when I was in the flight surgeons course, they put us in an altitude chamber, and they take us up without oxygen. They take us up. I think the Army took us up 25 or 30,000 feet. The Air Force used to take their guys to 40,000 feet, and they killed a couple, but without oxygen. So we get up, and they get you up to like 8 or 9,000 feet, and you start looking, and you figure out your night vision's not what it was at ground level. And then you get up to maybe 15,000 feet, and they give you a coloring book with all these vivid colors, and it's all black and white, and it's gray, and they put an oxygen mask on you, and it like lights up in colors. It's amazing. But the fact is, if you're a smoker, you're at about 8,000 feet all the time. So I used to joke that if you're going to fly in a commercial airline at night and you see the pilot out smoking a cigarette, well, he's already at 8,000 feet on his vision, and he can't see anything. They always check carbon monoxide levels after aircraft accidents, and there's a case where a guy crashed a helicopter and they get his carbon monoxide level. Well, he was a smoker, and he had survived the crash and chain smoked double-handed for like an hour getting to the hospital, and his carbon monoxide levels were off the wall. But so it's normally 0, 1, 2%, and then it depends on what your exposure is by smoking, what happens from there. But the carbon monoxide level might not correlate to the symptoms. So patient had a significant exposure, now you've got them out, they're dropping, they may still have significant symptoms. It really depends on their time out of the environment. So at the scene, once again, every single thing that you guys do, the first thing is scene security and your safety and the safety of your team. So once again, and I know you've heard this story before, when I was a young EMT, and this was back in the days when we had funeral directors running ambulances in Fairmont, West Virginia, they killed 2 or 3 people from the guys walking up on the porch, and there were 2 victims in the house, so they charged right in, and now there's 4 victims in the house. And true story, scene security is important. So this is one of those where if you suspect it, ventilation's critical. Ideally, self-contained breathing apparatus, getting the fire department involved, checking the atmosphere, all those things are really necessary. So 80% of fire fatalities in the first 12 hours are due to carbon monoxide. And, some of these people, you talk about deaths in fire scenes, 30% it was just due to carbon monoxide. And of those, a third of them had some alcohol on board as well. So we talk about combustion products. So if a fire got lit in this room right now, you've got wood that's going to go up, you've got this stuff, you've got carpet on the floors, there's all kinds of nasty stuff that comes out of here. First and foremost, carbon monoxide. That's the thing we're talking about. But from any synthetic wools, plastics, there's the potential for cyanide generation. And that's a whole talk in and of itself. Everything in complete combustion is carbon dioxide. If you have nitroglycerin, aniline dyes, you can get methemoglobin, phosgene from plastics, ammonia. Well, where's ammonia at that we got to deal with? 2 power plants with ammonia on site. And so if you check in, have you had ammonia training? Yeah, no. So, that's a corrosive upper airway injury. And then you talk about just soot, just the smoke has all these things in it, but then it just has particulate matter, flecks of wood and carpet and everything else that's been aerosolized. Now you inhale that. That's problematic in of itself. So Euro, scene security, recognize the problem, ventilate the area, get the victim out of the toxic environment, ABCs, get the vital signs, secure the airway, get the patient on high flow oxygen. You'll never be wrong doing that coming out of a toxic environment like this. ALS role, obviously airway, always check the sugar. Don't get fooled by someone with that. High flow oxygen, get the EKG, IV access, and mobilize as indicated. Again, we're not using boards a lot anymore, but certainly mobilizing other things is appropriate. Get them on a monitor. If someone has a significant carbon monoxide exposure and you just put them in room air, 4 or 5 hours it'll be washed out. That's how long it takes to get cleaned out. If you put them on 100% oxygen, now we're down to 1 or 2 hours to be washed out. If you put them in a hyperbaric chamber, it gets down to 20 or 30 minutes. So it's critical to administer oxygen as soon as possible. And I'm not going to get into the hyperbarics, and the things that it's useful for and not useful for and things. But the fact is, the pressure of the oxygen administered to the patient determines how long it takes to wash out the carbon monoxide. So if someone's got a serious exposure, you can expect hypotension. You got to get IV access. You want to fluid resuscitate them. Then you want to watch out if you're fluid resuscitating them. We just talked about, well, maybe the heart's not working so well, so you can get the potential for flash pulmonary edema, so you've got to be careful with the volume of fluid you're giving. We talk about the delayed effects of carbon monoxide. And so 4 to 6 weeks after the exposure, this is the patient who may not have gotten high flow oxygen or may not have gotten hyperbaric oxygen. They're the ones that are at risk, and all of a sudden they begin developing this delayed neuropsychological sequela, as it's called. So they are disoriented. They may their judgment's not what it was. They can't concentrate on task. Get this Parkinsonian-like, the tremors and the shuffling gaits and the personality changes and visual disturbances, and all this is kind of slow onset, but it's very real after a significant exposure. So at the fire scene, we want to be watching for, obviously, the thermal injuries, the upper airway injuries, looking for soot in the airway, listening for stridor, looking for respiratory distress, treating the shock, treating the wheezing and bronchospasm. We can do that easily with albuterol and so forth. We want to remember thermal injuries, the rule 9s we talked about, 18% front, 18% back, 18% each leg, 9% each arm, 1% perineum, 9% for the head. Remember your minor burns, less than 5% total body surface area. Serious burns, 5 to 15%. Critical, greater than 15%. Remember your calculations for the Parkland formula and burn dressings. That's right off of Protocol 40. So, wrapping things up, we talked about burns. We talked about the mortality from burns or from thermal exposure many times is the carbon monoxide. It is a silent killer. Any combustion source, anything with a flame, can generate carbon monoxide. And it's important that all of us in public safety talk to our citizens that, yeah, you need smoke detectors, but if you got a fire in the house, if you got anything with a flame, a digital carbon monoxide detector is really as important as a smoke detector and can prevent a lot of deaths. So that's it. We're doing next month and I've got to look at the date, is the kind of best of series. I think we're on for December the 8th, which is the second Thursday. And what we're going to do is take the lectures from this year and kind of have some fun with them and just do some review. I'm working with Glenn now on a schedule for next year, and I understand that the rules have changed considerably at the state level for requirements for continuing education and actually including what topics need to be taught. So some of the topics that were done this year are going to be done again because it's mandated. And so we're going to be talking again next year about stroke and heart, but I think we've got psych emergencies and some other stuff on. So we're working on that schedule now, and I'm delinquent in getting it back to Glenn, but we're looking at again trying to provide 10, 12, 15 hours of this kind of C continuing education for you guys next year. So, any questions tonight? Yes, sir.
What do you think carbon monoxide poisoning, what kind of effect would you think you would see with somebody with AFib?
Well, their cardiac function certainly has the potential to not be as good as it was. With AFib, you lose 25% of your cardiac output just because the top of the heart's not working. So now I would think that you would be at more risk quicker for hypotension, for potentially pulmonary edema, because your cardiac output is already down if you've got rapid or uncontrolled AFib the way it is. But I think the bigger risk would be someone with known coronary artery disease, or worse, unknown coronary artery disease. Who has narrowed coronary arteries, and all of a sudden you drop your oxygen carrying capacity so that you can't get the oxygen through to the myocardium.
So if there's like in a group and one of them was AFib, the rest would probably be symptomatic with just headache. This guy.
Well, yeah, I think they would be at higher risk for cardiac-related events. Yeah, yeah. I think that would certainly be a reasonable assumption.
He might be the canary.
Well, you never know. All right, well, guys, thank you all for coming out. I hope everybody has a great Thanksgiving, and certainly stay safe on the roads. Good night. Thanks.